It's time for another warm-up review. Let's get going. Describe the changes seen in serum calcium, serum phosphate, alkaline phosphatase, and PTH in each of the following diseases. So first we have primary hyperparathyroidism. So what does that start with? Well, this starts with elevated PTH. Elevated PTH is going to raise serum calcium, which will trash the phosphates and will raise the alkaline phosphatase level. Next, what about Paget's disease of bone? So this has nothing to do with PTH, but you have increased bone turnover. So you're going to raise your alkaline phosphatase. Vitamin D toxicity. So this is going to result in increased absorption of calcium. So the serum calcium will be increased. Now as a consequence, PTH is going to go down. And as a consequence of that, you're not going to be trashing that phosphate, and the phosphate will go up as well. The alkaline phosphatase will be unchanged or normal. Next, what roles do Leydig cells and Sertoli cells play in male spermatogenesis? So Leydig cells are stimulated by LH and they produce testosterone. Now Sertoli cells are stimulated by FSH and they provide support like nourishment to the developing spermatozoa. Next, what is the mechanism of action of sildenafil? So sildenafil is a phosphodiesterase inhibitor. So it inhibits cyclic GMP phosphodiesterase, which causes an increase in that cyclic GMP. And that leads to relaxation of smooth muscle, and specifically smooth muscle in the corpus cavernosum. Now all of this leads to increased blood flow and erection. All right, that's it for the review. Let's get to the video.
In this video, we're talking about breasts and breast pathology. Eyes up here. We reviewed basic breast anatomy and physiology in the video on the female reproductive cycle, and we discussed the roles of prolactin in stimulating milk production and oxytocin in stimulating milk ejection. But there is one important breast pathology related to breastfeeding, which is acute mastitis. Mastitis is basically an infection of the breast, usually due to Staph aureus. Breastfeeding leads to cracking of the nipples, which allows the bacteria to enter. And that leads to cellulitis, which can progress to an abscess. So clinically, you'll see redness, pain, and potentially some fever. And you can sometimes treat mastitis and cellulitis with antibiotics. But if you feel a fluctuant mass under the skin that makes you suspect an abscess, the next step would be to do an ultrasound of the breast to confirm the diagnosis of an abscess, and then needle aspiration to drain the abscess or surgical drainage if necessary. It's important to remember that we want to keep breastfeeding during mastitis. The bacteria in the milk aren't dangerous for the infant. And if a woman has opted not to breastfeed, she needs to keep pumping because that helps to clear that infected fluid out of the breast. Let's briefly discuss gynecomastia, which is the development of breast tissue in men. A lot of different things can cause gynecomastia, especially things that result in high estrogen levels. You can see gynecomastia in infancy and in the elderly, and especially in puberty, when up to 70% of adolescent boys can have some transient gynecomastia. Testicular tumors can raise estrogen levels, and so can cirrhosis. And you can see gynecomastia and Klinefelter syndrome, also from a bunch of different drugs. And this is probably the highest yield thing about gynecomastia for your test. So they might give you a patient with gynecomastia and ask, which of the following drugs is most likely the cause? There are several mnemonics for the drugs that cause gynecomastia. The one I like is STACT, even though it's not the most PC mnemonic around. The S is for spironolactone. T is for THC, so marijuana can cause gynecomastia. The A is alcohol, specifically chronic alcohol use. The C is the H2 blocker cimetidine. K is ketoconazole, and the E is for estrogens, which should be pretty obvious that if a man is taking estrogens, that could lead to some breast development. And the D is digoxin. Now, let's talk about some benign breast conditions before we get to breast cancer. In your study guide, there's a list of benign epithelial lesions, which we divided into proliferative changes and non-proliferative changes. We're going to talk about the non-proliferative changes first, which are sometimes called fibrocystic changes, or it used to be called fibrocystic disease, but now we just talk about it not being a disease, but just being a benign change in the breast tissue. It's really just an increase in benign fluid-filled cysts and fibrous tissue. So it's fibrocystic. But the key feature is that it's non-proliferative, despite what you may see in some review books. There is no proliferation of cells, so we classify this as non-proliferative. Non-proliferative changes are the most common cause of breast lumps in women ages 25 to about 50 when menopause happens. And the reason that they become less common after menopause is that these fibrocystic changes fluctuate with hormone levels. Clinically, these patients present just before their periods complaining of breast pain and multiple bilateral breast lesions. Again, these are hormone sensitive and these changes fluctuate in size over the course of the menstrual cycle. They tend to be worst just before menstruation, and then it regresses somewhat after the period is completed. So if a young woman comes in complaining of a breast lump and you examine her and suspect that this is non-proliferative fibrocystic change, you might just re-examine it about a week after her period is completed, when it's going to be the smallest. True breast tumors don't change with the menstrual cycle. They stay relatively stable in size. So in the study guide, you see that there are two basic histological findings in these non-proliferative fibrocystic changes: fibrosis and cysts. The fibrosis we're talking about, hyperplasia of the breast stroma, the connective tissue. These are not neoplastic tumors. There are just areas of dense hyperplastic breast stroma. And then the cysts are fluid-filled cavities that look bluish in color. So they are called blue dome cysts. Here we see a gross specimen of fibrocystic change, and you can see cystic cavities, including this, which is vaguely bluish, I guess, and the rest of the lump is just dense fibrous connective tissue. The other thing to mention is that these non-proliferative changes can sometimes be caused by caffeine or dietary fat. So if women are really symptomatic with cyclical pain from these changes, decreasing their caffeine intake can really help with their symptoms. Then the next group of bullets are the proliferative changes without atypia. So these have proliferation of cells, but there are no atypical cells. These aren't precancerous. The first one of these is sclerosing adenosis. Adenosis means increased glandular tissue or increased acini. The acini are so increased that they become compressed and distorted inside of the lobule, and this leads to intralobular fibrosis, which is what sclerosing refers to. The adenosis leads to sclerosis, and there can be some calcifications which can be suspicious for cancer on the mammogram. But again, this is completely benign. The next one is epithelial hyperplasia, where you have an increase in the epithelial cell layers in the terminal duct of the lobule. There's also a complex sclerosing lesion, which is sometimes called a radial scar. It's a scar with an irregular shape that can look like invasive cancer on mammogram. It looks like fat necrosis. Fat necrosis is where you have some injury to the breast and the fat tissue dies and becomes necrotic, and that leads to a painless lump. A radial scar looks similar on mammogram, but there's no prior history of breast surgery or breast trauma. And then the last type of benign proliferative change I want to mention is fibroadenoma. These used to be classified as non-proliferative, but that's no longer the case. A fibroadenoma is actually cellular tumor. This is one of three types of benign breast tumor that I want to talk about: fibroadenoma, intraductal papilloma, and a phylloides tumor. Fibroadenomas are the most common breast tumor in women under 25. It's a small, firm mass with regular edges, and it's not adherent to anything, so it's mobile. And it can increase in size with estrogen exposure, so it will get larger and maybe more tender with pregnancy and with menstruation, but it's not a precursor to breast cancer. Histologically, you see a proliferation of stroma, but this time it's cellular stroma that squeezes the purple glandular elements until they become compressed and elongated. The second type of benign breast tumor is intraductal papilloma, which is a very small tumor that's found inside of the lactiferous ducts. beneath the areola. It's intraductal inside the ducts, and it creates either a serous or bloody nipple discharge. It's the most common cause of a fluid discharge from the breast other than milk. So if they give you a patient with a straw-colored nipple discharge or a slightly bloody nipple discharge, think about an intraductal papilloma. And this one carries a very, very tiny increase in the cancer risk. And our third benign tumor is a phylloides tumor. Instead of being a small tumor, this is a large, bulky tumor with leaf-like projections on histology. That's the key term for your test, leaf-like. Phylon is the Greek word for leaf, and you might remember leaves have chlorophyll, phylloides tumor. I'm not sure who decided this looks leaf-like, but that's the classic description. What I see are well-defined projections of tissue with lots of inlets, almost like fjords. And at higher magnification, these projections are lined with purple epithelial cells. But if they use the phrase leaf-like, think phylloides tumor. Phylloides tumors are more common in women in their 50s, and generally these are benign, but occasionally they can become malignant. Now let's talk about malignant breast tumors, or breast cancer. Definitely important USMLE and COMLEX. Breast cancer is the most common cancer in women, and it's the second most common cause of cancer death after lung cancer. And is breast cancer more common in younger women or older women? Older women, post-menopause. That's why we start mammograms at age 40. The most common location of breast cancer is the upper outer quadrant of the breast, near the axilla. And the single most important prognostic factor is whether or not the lymph nodes are involved at the time of diagnosis. There are several important risk factors for breast cancer, but the main one is estrogen exposure. The more menstrual cycles a woman goes through, the higher her risk of breast cancer. So, an early menarche or late menopause are risk factors. Fewer pregnancies and less time breastfeeding are risk factors. Older age at the time of first live birth increases the risk of breast cancer, and obesity will increase the risk as well because the peripheral conversion of androgens to estrogen in adipose tissue. Family history of breast cancer is also important, and certainly a history of BRCA gene mutations or HNPCC. It's common to find an overexpression of estrogen and progesterone receptors in breast cancer tissue, as well as the HER2/neu receptor, which is the ERB2 gene. The presence of these receptors gives us targets for chemotherapy to attack those cancerous cells with drugs like tamoxifen, which binds to estrogen receptors, or trastuzumab, which binds to HER2/neu receptors. There are two basic types of breast cancer, ductal and lobular. Ductal breast cancer arises from the duct epithelium, and lobular breast cancer arises from the lobules, from the glands. Let's talk about some specific details about the different types of breast cancer. First, let's cover breast carcinoma in situ, which makes up about 15 to 30% of breast cancer. In situ means that the cancer cells are still situated where they arose. They haven't broken through the basement membrane and started invading locally yet. So again, if our two big breast cancer subtypes are ductal and lobular, we can talk about ductal carcinoma in situ and lobular carcinoma in situ. Let's talk about ductal carcinoma in situ. We abbreviate this as DCIS, and it's also called intraductal carcinoma. It's intraductal. It is contained within the duct and hasn't broken through yet. It arises from ductal hyperplasia, and then the cancer cells fill the lumen of the duct, but there's no penetration of the basement membrane. That's what keeps it from being invasive cancer. There are 5 different morphologic subtypes of DCIS. The first of these is cometacarcinoma, which is characterized by central necrosis. After that, you have solid, cribiform, papillary, and micropapillary. There's also something called Paget disease of the breast, which is technically not a subtype of ductal carcinoma in situ, but it's a way that DCIS can present. With Paget disease, you see eczema-like patches on the nipple and areola, which suggests an underlying carcinoma. Microscopically, you see cancer cells interspersed within the epidermis, and on higher magnification, the cancer cells are surrounded by a clear halo. But the real issue is that Paget disease is often associated with underlying DCIS. So if you see Paget disease, you need to evaluate further for underlying cancer. The other type of carcinoma in situ is lobular carcinoma in situ, or LCIS, which is characterized by signet ring cells. A signet ring cell is a cell that's filled with mucinous material, which pushes the nucleus to the periphery so that it looks like a signet ring, a ring that's thicker on one end, kind of like a class ring. We also see signet ring cells in Krukenberg tumors, which is a gastric adenocarcinoma that metastasizes to the ovary. LCIS is basically always ER and PR positive. There may be a rare exception now and then, but in general, these are always ER and PR positive. Remember that for your test. And again, hormone receptors are useful because they give us targets for treatment. LCIS is a risk factor for lobular carcinoma, but it's not clear that these LCIS tumors actually progress to invasive carcinoma. With DCIS, those cancers eventually do break through the basement membrane and they do become invasive. So when you find DCIS, you want to remove that tumor because if you leave it alone long enough, it can transition into carcinoma. But with LCIS, it's not that necessarily the case. You don't have to take out those cells because even if you do, the chance of getting sporadic lobular carcinoma in other parts of the breast is still really high, even in the contralateral breast. That's why these patients consider mastectomy or tamoxifen to try to prevent invasive cancer in the future. Now, let's get into the invasive breast cancers. The first type is invasive ductal carcinoma. This is by far the most common type of invasive breast cancer. It makes up 75 to 80% of invasive breast cancers. It's the most common and unfortunately the most invasive. It arises from DCIS and it's a firm, rock-hard mass with sharp margins. So it can feel a lot like a fibroadenoma, which is why biopsies are so important. One difference between these two is that fibroadenomas are mobile and invasive cancers tend to be attached to other tissues, so they are fixed and immobile. On biopsy, the histology is very heterogeneous. But one very recognizable feature is this stellate or star-like border of the tumor. The next one on our list is invasive lobular carcinoma. This type of cancer can be multiple and bilateral. It's associated with inactivation of the E-cadherin genes, and generally it's ER and PR positive. And on histology, you'll see those signet ring cells again. Another classic histologic finding of invasive lobular carcinoma is that tumor cells tend to line up in little single-file rows. Be sure you can recognize that. Ductal carcinoma and lobular carcinoma are the two most important types of invasive breast cancer to know for your test, but just for completeness, we've listed several other types. Medullary carcinoma is a fleshy, cellular mass with lymphocytic infiltrates. Then there's tubular or cribiform carcinoma, mucinous carcinoma, papillary carcinoma, and metaplastic carcinoma. And then I want to briefly call your attention to inflammatory carcinoma. This isn't really a subtype of invasive carcinoma, but it's a way that invasive carcinoma might present. Inflammatory carcinoma occurs when you have cancer that invades the dermal lymphatics and it leads to visible inflammatory changes. Signs of inflammatory breast cancer may include peau d'orange, which is the orange peel texture to the skin, which comes about because of lymphatic obstruction, and to lymphedema, which causes the skin to thicken. You can see focal dimpling of the breasts because of cancer that involves the suspensory ligament of the breast. You can also have nipple retraction. Now, some women have nipple retraction at baseline, and that's okay. But if there's a change with new nipple retraction late in life, you have to worry about some ductal involvement, pulling the nipple in. Let's also talk briefly about a couple of classes of medications used to treat breast cancer. The first class is the SERMs, or selective estrogen receptor modulators like tamoxifen and raloxifene. These are drugs that bind to estrogen receptors, but they have either agonist or antagonist properties in different tissues, which is why they are called selective estrogen receptor modulators. And each one of the SERMs has its own unique profile of where it acts like an estrogen receptor agonist and where it acts like an estrogen antagonist. Tamoxifen is the classic one used for breast cancer. It's an estrogen antagonist in breast tissue. So if we have an estrogen receptor positive breast cancer, if we can use tamoxifen, it will block the stimulatory effects of estrogen on that cancer. We use tamoxifen to treat primary breast cancer. We also use it to prevent recurrence of estrogen receptor positive breast cancer, and we use it for primary prevention in some high-risk women. Remember, LCIS is one situation where you might use that, but the problem with tamoxifen is that it's an estrogen agonist in endometrial tissue, so we have to watch out for increased risk of endometrial cancer. Raloxifene is another SERM, and it has a unique profile. It's an estrogen agonist in bone, and it's primarily used for osteoporosis. It reduces bone resorption, so it helps with osteoporosis. And it's also an antagonist in the breast, so it can sometimes help with breast cancer as well. But it doesn't cause an increased risk of endometrial cancer like tamoxifen does because it's not an estrogen receptor agonist in the uterus. And then another category of medicines would be the aromatase inhibitors like anastrozole. Anastrozole inhibits the production of estrogen by inhibiting the enzyme aromatase, which is an important step in the conversion of androgens to estrogens. We use anastrozole in postmenopausal women with breast cancer. They have low levels of estrogen anyways, but anastrozole decreases the estrogen levels even further. The problem is that this low estrogen also affects the bones, so it increases the risk of osteoporosis and fractures. Now let's pause and work through the end of session quiz, and we'll go over the answers. Let's get going. First question, what are some of the causes of gynecomastia? Hyperestrogen states like puberty, cirrhosis, testicular tumors, Klinefelter syndrome, and drugs. Remember the mnemonic STACKED. Spironolactone, THC or marijuana, chronic alcohol use, cimetidine, ketoconazole, estrogens, and digoxin. Next, what organism is most commonly responsible for acute mastitis? This is usually caused by Staph aureus. Next, what is the classic presenting complaint in a patient with intraductal papilloma? Straw-colored or yellowish nipple discharge that may or may not also be bloody. Next, what breast pathology fits each of the following descriptions? The most common breast tumor in women under 25 is a fibroadenoma. The most common breast mass in a postmenopausal woman is invasive ductal carcinoma. The most common breast mass in premenopausal women, that's a non-proliferative change, fibrocystic change. The most common form of breast cancer, again, that's invasive ductal carcinoma. A small, mobile, firm mass with sharp edges in a 24-year-old woman. The only thing you really have to go on here is her age. Young woman, think fibroadenoma. Histological leaf-like projections, that's a phylloides tumor. Signet ring cells, that's LCIS, most commonly lobular carcinoma in situ, but those cells can also be seen in invasive lobular carcinoma. Loss of E-cadherin cell adhesion gene on chromosome 16. That's both LCIS and invasive lobular carcinoma. Always ER positive and PR positive, same thing. Both LCIS and invasive lobular carcinoma. Commonly presents with nipple discharge. That's the intraductal papilloma. Eczematous patches on nipple. That's Paget disease. Whenever you see problems with the nipple and the areola, think about Paget disease. Multiple bilateral fluid-filled lesions with diffuse breast pain. That's non-proliferative fibrocystic change. And the last one is a firm fibrous mass in a 55-year-old woman. This is most likely cancer. And the most common breast cancer is invasive ductal carcinoma. And our last question says, a 58-year-old postmenopausal woman is on tamoxifen. This medication increases her risk of developing what condition? Endometrial cancer. That wraps up the quiz, but we also have some rapid-fire facts to go over. The most common cancer in women in the U.S. is breast cancer. The most common benign breast tumor is a fibroadenoma. And the most common malignant breast tumor is infiltrating ductal carcinoma. A blue dome cyst in the breast should make you think of fibrocystic change. The treatment for ER-positive breast cancer should include tamoxifen. And finally, red, itchy, swollen rash on the areola and nipple. Again, anytime they start talking about the areola and nipple, think about Paget disease. That's it for this video. Okay, you guys, that's all for me. I've enjoyed going over this material with you. Best of luck on your test.